Hello, everyone. My name is Mary Muko. I'm a specialist on the Provider Outreach and Education team at WPS Government Health Administrators, or WPS GHA. I will be your speaker today, and assisting me is my friend and colleague, Bailey Lawson. She may help during the question and answer portion of today's call. We begin our webinar today with this disclaimer, and we include this in all of our education to inform learners that we made every effort to ensure that the education we provide is current and accurate. The information, however, is subject to change. CMS publishes relevant laws, regulations, and rulings on their website. Answers to questions are based on the facts given, but CMS published information and instruction and rules will always prevail, and this is what determines final Medicare coverage. Just as a reminder, CMS prohibits recording of this presentation for profit-making purposes. Today's webinar is the sixth and final webinar in a series of webinars designed to provide an entry-level introduction to Part B mental health services. The services that we're talking about today and have been talking about in this series are those that are submitted on the CMS 1500 claim form or the 837P electronic claim. During this series, we have often referred to a very informative CMS publication for those who render or prepare and submit those Part B claims to Medicare. The title of it is Medicare and Mental Health Coverage. It is a Medicare Learning Network or MLN product. The product number is listed here on this slide for you. And the most recent version is May of 2023. So I did want to include that in this presentation because it is a very valuable resource for all of you who bill for Part B mental health services. WPS has also published a local coverage determination. It is one that provides instruction for mental health services. It's called Psychiatry and Psychological Services. You can find that on our website. There is a list at the bottom of this slide of those items that we advertise would not be included in this webinar series. You can see them listed there: behavioral health integration services, psychological and neuropsychological testing. There's actually a local coverage determination by that title out on our website, and also opioid treatment programs. But today, our focus is on Part B Incident 2 services. And just as advertised during today's webinar, I'm going to explain the concept of Incident 2. I'm going to share with you the CMS criteria for billing Incident 2, and I'll explain who can bill and who can render Incident 2 services for Medicare Part B claims. So let's start out with answering the question here. What is Incident 2? Incident 2 is a Medicare payment concept, and it's often not recognized by other payers. I think we would all agree that Medicare providers receive Medicare payment for those covered items and services they personally render for eligible beneficiaries. But under the Incident 2 payment concept, a provider bills for covered items and services that are rendered for the eligible beneficiary by another qualified individual. So Incident 2 may be allowed only for established patients or subsequent patient visits. It never applies for a new patient. Incident 2 is incidental services, so it doesn't apply for new patients. This means that an initial CPT code is never reported as an Incident 2 service. And Incident 2 applies then only for established problems. If a new problem is reported during a patient encounter, the service is not Incident 2. When documentation justifies that all of the Incident to criteria is met, Medicare will make payment to the billing provider based on the billing provider's fee schedule allowance. So, for example, if the encounter was rendered by a Medicare enrolled clinical social worker and the Incident to service is billed by the supervising physician, Medicare's payment, if all of the criteria for Incident to is met, Medicare's payment is paid at 100% of the physician fee schedule allowance instead of at the clinical social worker's fee schedule allowance. And that allowance would have been 75% of the physician fee schedule allowance if the service had been rendered and billed by a Medicare enrolled clinical social worker. So I've included this slide then to show you the fee schedule allowance differential. If a physician bills for a particular CPT code and it's allowed by Medicare, we will allow it 100% of the physician fee schedule. Of course, Medicare pays 80%, and then the beneficiary or his or her supplemental insurance would be responsible for that remaining 20%. But for a non-physician practitioner, Medicare will allow that same CPT code at 85% of the physician fee schedule. So, for example, if the physician would receive $100 for a service, or that would be the allowed fee schedule amount, a non-physician practitioner's allowed fee schedule amount would be $85. That's 85% of the fee schedule, or that 100% fee schedule. A clinical social worker, on the other hand, is allowed at 75% of the physician fee schedule. And beginning January 1 of 2024, licensed professional counselors and marriage and family therapists who enroll in Medicare would be allowed at 75% of the physician fee schedule allowance. So, who can bill for Incident to mental health services? And I'm talking about Medicare here. Only 7 provider types can bill for Incident to. And when I say bill, what I'm talking about is submitting a claim to Medicare. So I'm talking about those Medicare enrolled providers who can submit a claim to Medicare and receive payment for services rendered Incident to. This slide shows those 7 provider types who can submit a claim and be paid for services rendered by someone else under Medicare's Incident to payment concept. I'm going to talk a lot today about a billing provider versus a rendering provider. A billing provider is the individual or the enrolled provider that is eligible to submit claims to Medicare. And the rendering provider, while he or she may be enrolled, it also could be someone who's not enrolled in Medicare. So there's a big difference in who can bill and who can render. So these then are those that can bill or submit a claim to Medicare for mental health Incident to services. They are a medical doctor, MD, doctor of osteopathy, which is DO, clinical psychologist, CP, clinical nurse specialist, CNS, nurse practitioner, which is an NP, physician assistant, PA, and certified nurse midwives, or CNMs. So this is a mental health webinar today. What about clinical social workers? I've included this slide because it provides the answer to one of the most commonly asked questions about Incident to for mental health services. The question we often receive is whether a Medicare enrolled clinical social worker, one who is enrolled with our provider enrollment department, whether that CSW can bill Medicare for Incident to services, and the answer is no. And remember that I said bill means submit the claim. A Medicare enrolled clinical social worker cannot bill for Incident to services. However, a clinical social worker, whether they're enrolled or not, may be eligible to render an Incident to service, but it must be billed by one of those 7 provider types that I just talked about on the previous slide. So this means then that they can provide the Incident to service during that patient encounter, but they cannot submit the claim for it. They cannot bill for it. The supervising provider must bill for the service. Medicare can allow payment when the incident to criteria is met, and payment will be made then at the billing provider's Medicare physician fee schedule allowance if that incident to service is rendered by a clinical social worker. Language in Section 1861 of the Social Security Act, and I included an embedded link here to that section of the Social Security Act. You'll find many links in the presentation handout that you received for today's event throughout the entire presentation, and those are those resources that I advertised that I would share with you during today's webinar. So language in the Social Security Act states that Incident 2 does not apply for any service that has its own payment category. And this slide shows a list of examples of those services that have their own payment category for Medicare. Those with their own payment category, such as diagnostic tests, flu shots, screening mammograms, clinical lab services, all of those listed here on this slide cannot be paid for under Medicare's Incident to payment concept, and that's based on the law, specifically the Social Security Act, Section 1862, or excuse me, 61. For Medicare to consider payment under the Incident to payment concept, documentation must exist to meet CMS's 5 key criteria for payment. The service must be a professional service. The service must be rendered in a non-institutional setting. An employment relationship between the billing provider and the rendering provider must exist. The services must be incidental. Remember, it can never be a new patient service. It must be incidental. And there are supervision requirements that exist. And I'm going to talk about each of these in more detail. This slide shows some examples of professional services that may be considered for payment under the Incident to concept. Evaluation and management is listed first, and for these, the non-physician practitioner would report the level of E&M service based on their documentation, and ancillary staff can only code to the 99211 level of service in order for the services to be payable under the Incident to payment concept. And of course, all of these services would need to be appropriately documented. So if the non-physician practitioner reports at a level 99213, that documentation would need to support that level of evaluation and management. Remember, of course, that ancillary staff can only report as high as the 99211 evaluation and management code level. That too would need to be documented in the patient's medical record. Other services that may be rendered Incident to would include chronic care management and transitional care management. Be certain that the documentation justifies that incidental service and that the rendering individual is performing only services that are under his or her state scope of practice. We get asked a lot of times, well, who can render an Incident to service? And while CMS doesn't have a list of those that can render an Incident to service, as long as all of the key criteria is met and that individual is rendering a service based on his or her state scope of practice, typically that means that he or she is certified or licensed in his or her state to render those service, they would be eligible to render, not bill necessarily, an Incident to service. Other examples of professional services that may be rendered under Incident to is the administration of an injection, and that would include the drugs. A couple of things to remember when we're talking about administrations of injections is that if that drug is not payable by Medicare, then the administration of that drug is also not payable by Medicare. Payment for a minor surgical procedure rendered by a non-physician practitioner can also be considered for payment under the incident to payment concept, as long as all of the CMS key criteria for incident to is met. And of course, you would use or report on your claim that procedure code that supports the incident to service. Next, I'm going to talk about location. This is another of the 5 key criteria that CMS has in the Internet-only manual instructions for coverage of services under Medicare's incident to payment concept. Remember, the first that was that it needed to be a professional service. The second of the 5 key criteria is for location. Medicare can only consider payment for an incident to service when the service is rendered in a non-institutional setting. And I've listed some examples for you here on this slide. Office or clinic, nursing facility, even the patient's home, but there are additional requirements listed in the Internet-only manual, and I've included a link to that section of the manual, when an incident to service is rendered in a patient's home. And I'm going to cover those in more detail later on in my presentation. The third of the, well, back up here just a moment. I want to talk a little bit more about institutional setting examples. This slide is listed because remember that Medicare can consider payment for incident to services when the services are rendered in a non-institutional setting. And this slide then shows examples of the institutional settings as defined by CMS. So in or outpatient hospital and skilled nursing facility. If your patient is in one of these institutional settings, it does not meet incident to requirements or criteria for coverage. Now on to employment status. This is the third of CMS's 5 key criteria. The rendering provider or individual must have an employment relationship with the billing provider. And you might have caught it that I said rendering provider or individual. When we say provider, typically we're talking about an individual who's enrolled by Medicare, but sometimes there are individuals that are qualified to render an incident to service that aren't enrolled in Medicare. So that's why I'm saying the rendering provider or individual must have that employment relationship with the billing provider. And that rendering provider or individual can be a W-2 employee. And in this case, there is direct employment, and the billing provider provides a W-2 form to that rendering provider or individual at the end of the year. And in such a case, then the provider would be paying those employment taxes. The rendering provider or individual can also be a leased employee, and in this case, the leasing company is responsible for the activities of employment, and the billing provider reimburses the leasing company based on their contract. The lease may be a certain number of hours, or it could even be for specific days of the week. I have more information for you about employment status. Contracted employees may render an incident to service. The stipulations for work would be based on the contract. The rendering individual in this case takes care of their own taxes and insurance, etc., as you see listed here on the slide. The final employment relationship that I want to talk about could be those situations where both the billing provider and the rendering provider or individual are both employed by the same group or the same entity. These would have the same tax identification number. On to the fourth criteria of CMS's criteria. The fourth criteria is that the service must be an incidental service. It is the billing provider who decides the patient's diagnosis. The medical decision-making should be documented in the patient's medical record by that billing provider. The plan of care then is the document that includes the provider's plan that describes the type and the frequency of services that a particular patient needs. So for Medicare to consider payment under the incident to concept, the rendering provider or individual service must be included in the billing provider's plan of care. In other words, the rendering provider or individual has to be following that billing provider's plan of care. It has to be an incidental service in order to qualify for incident to payment. So any deviation at all whatsoever or any change in the plan means that the service is no longer incidental. So if a patient or if during a patient encounter with that rendering individual or provider, if during that encounter the patient reports a new problem, that means that any service that's rendered is no longer going to be based on that plan of care of the billing provider. So the service would no longer be considered incidental. You cannot deviate or change anything in the plan of care and still receive payment for incident to services. That cannot happen. There should be evidence in the billing provider's documentation that shows that he or she actively participates in the patient's care, and it would be he or she that manages the patient's diagnosis. There must be documentation to show this. Incident to does not mean a transfer of care of the patient. So while the billing provider does not need to co-sign each encounter note, it is expected that the documentation will show that the billing provider continues to follow the patient, and that would need to be included in the record. Some sort of documentation that he's actively treating or she is actively treating that patient and managing the care of that patient. So if Medicare would ask for medical record documentation, and I'm talking about any Medicare contractor, this could be one of the review contractors. If you are asked to provide records for a service that is an incident to service, you should include in the documentation when you return it to Medicare the documentation that supports that that billing provider remains actively involved in the management of that patient. So just something to remember. The fifth and final criteria for the incident to or CMS coverage of incident to services is that supervision be provided. I'm getting ahead of myself here. I apologize. Right here, got my my slides out of order, and I apologize for that. So there's a couple of different supervision levels that we talk about when we speak about incident to. For incident to services, those are two levels of supervision that could be required depending on what kind of services are being billed, are direct supervision and general supervision. Direct supervision is required for medical services, and general supervision is required for behavioral health services furnished for diagnosis, evaluation, or treatment of a mental health disorder or substance use disorder, that being an SUD, with co-occurring mental health disorder. All right, so let's talk about this just for a little bit. Direct supervision means that the provider is in a proximate location and immediately available to provide help if needed. It doesn't mean the supervising provider needs to be in the same room. One of our former contractor medical directors actually coined the phrase speaking loudly distance. At one of my previous presentations, someone in my audience actually suggested the phrase holler down the hall distance, and these both work well to explain proximate location. For those providers who are in a multi-physician office, another physician may step in to provide that direct supervision should the provider treating the patient not be available, out of the office that day, perhaps on vacation, just not available. So in that case, this would be evident to Medicare because in item 24J, or the electronic equivalent of the claim, it will say, or you will need to place there in 24J the NPI of the supervisor. And there are claims processing instructions in Chapter 26 of the Medicare Claims Processing Manual. That's Manual 100-04. I'm talking about the internet-only manuals. And for item 24J in Chapter 6, it tells you where to put that NPI of the supervising physician. Beginning in calendar year 2023, only general supervision of the billing provider is required for behavioral health services. I've listed again here on this slide for you for behavioral health services. CMS says for the diagnosis, evaluation, or treatment of a mental disorder or substance use disorder with co-occurring mental health disorder, the supervision requirements for behavioral health services billed for patients with these diagnoses, with these conditions, is general supervision when a service is rendered incident to. And one common question that we have been receiving is whether the administration of an injection of a drug that's included in the treatment plan of the billing physician can be covered as an incident to service when administered for a mental health patient. And what we're talking about here is, can it be covered under general supervision? So here is the response from CMS that I received when I contacted them specifically. CMS indicates that they've actually already addressed this, and it was in the calendar year 2023 Physician Fee Schedule Final Rule. In the final rule, CMS publishes comments made by providers that are commenting on the proposed rule, and then it includes also the the uh, the response to that particular comment. So here's the comment. Many commenters requested that CMS specify which services are considered behavioral health services and would be eligible to be furnished under general supervision. They continued on and said that a few commenters urged CMS to define behavioral health services under the broadest terms possible for purposes of this provision. And here is how CMS responded to that comment. I'm going to read it to you. We do not define behavioral health services by HCPCS codes. We did not propose to do so, and we believe that individual practitioners are in the best position to determine whether particular treatments or diagnostic services are behavioral health services. However, we generally understand a behavioral health service to be any service furnished for the diagnosis, evaluation, or treatment of a mental health disorder. And they went on to say even more than that. They quoted some information from the calendar year 2022 physician fee schedule and said that the services, those that are the types of behavioral health services that would be eligible to be furnished by auxiliary personnel under the general supervision of a physician or certain other non-physician practitioners, is authorized under statutory benefit categories, and that these services could include but are not limited to such services as psychotherapy, screening, brief intervention and referral to treatment services, psychiatric diagnostic evaluations, and other services furnished primarily for the treatment of diagnosis or mental health or SUD disorders. And I can send this out to all of you following today's presentation. I know that was a lot of words for you to grab onto, but what I want to tell you here is that absent national guidance by CMS, WPS will not identify which services can or cannot be rendered under general supervision of a mental health provider that is billing an incident to service. However, we do want to remind providers to use clinical judgment as it pertains to patient safety when you are determining which incident to services to render under general supervision. So we asked CMS for guidance. They provided guidance. They did not provide specific national guidance. So WPS will not identify which services can or cannot be rendered under general supervision. That is going to be up to the judgment of the billing provider. Here's the next bit of information that I want to share with you today, and it goes back to location. I talked earlier about those locations, those non-institutional places of service where incident to may be billed, and here is that information that pertains to services rendered in a patient's home. When an incident to service is provided in the patient's home, there is certain criteria that appears in the Medicare Benefit Policy Manual in Chapter 15, specifically 60.4.1, that kind of restricts those services that can be rendered incident to in a patient's home. I've listed them here on this slide. So for Medicare to consider payment for incident to services in the patient's home, the patient, among other things, must be homebound based on 60.4.1 of Chapter 15. There would also need to be no home health agency that can provide that service that's being rendered incident to in the patient's home. So I did want to provide this information to you because we do receive questions from time to time about those incident to services in the patient's home. I want to talk just a little bit about documentation. Specifically, I've added some important documentation reminders here when you are billing for incident to services. Make certain that the service is appropriate for incident to, and that's of course going to be based on your documentation. You're going to need to make certain that that service that was documented doesn't have its own benefit category, or it can't be considered for payment under the incident to payment concept. You need to know the employment status for the rendering provider or individual. You need to be able to provide documentation to Medicare if Medicare asks for documentation for an incident to service. So you might need to, or you should, provide some sort of documentation that shows that employment status. Include the billing provider's plan of care when you're billing for an incident to service if you're asked for medical records. You may need to pull records from previous months. That plan of care may have been written 3 months ago. So for example, if the incident to service is rendered by a qualified individual in December, based on the plan of care that was written by the billing provider back in October, you should include that October plan of care that was written by the billing provider in your documentation that you submit for that December service. Let's talk a little bit about signatures. Medicare requires that a legible identifier be included in the records for a service rendered to a Medicare individual. And remember that the billing provider's signature or signature is not going to be required on each of those encounter notes that are entered by the rendering provider or individual, but there does need to be some evidence in that medical record documentation that the billing provider was rendering the supervision of that patient and that they remain actively involved in the care of the patient. And that, of course, goes right along with that last bullet there, your evidence for direct or general supervision. So you might ask, well, how do we show that the supervision was provided if the service was a behavioral health service that was rendered incident to for a mental health patient? You might have a schedule for the individuals in the office that day. That individual, that qualified provider, or enrolled provider that's going to be providing supervision that day for that particular patient or for all patients. You need to include all of that supporting documentation if you're asked to submit documentation and medical records for an incident to service. All right, that brings us to a bit of time that we have for questions. So I'm going to ask Bailey if there are any questions that we have received.
Yes, we have quite a few. The first one we have is just a clarification of, will you repeat the percentage of payment for licensed professional counselors?
Sure, I can do that. The percentage of payment that Medicare is going to allow for an incident to service that's appropriately documented, that meets all of the CMS criteria for incident to payment, will be based on 75% of the physician fee schedule.
Okay, thank you.
Oh, let me clarify that.
Okay.
If a licensed professional counsel is rendering incident to the physician, it's payable at 100% of the physician's fee schedule amount. For services that are being directly billed by a licensed professional counselor or a marriage and family therapist in 2024, if they're enrolled and they receive direct payment for their services then are paid at 75% of the physician fee schedule. And thank you for allowing me to clarify that. The incident to service is still going to be paid based on the physician's fee schedule amount, but if we pay directly to a licensed professional counselor or a marriage and family therapist, not incident to, it's going to be 75% of the physician fee schedule. Thank you.
Okay, thank you. So next question we have would be, can the social worker / psychologist bill incident to on the same day as a physician using an add-on code?
Can you read that question again, Bailey? I want to make sure I understand correctly.
Yes. Can the social worker / psychologist bill incident to on the same day as a physician using an add-on code?
I am not certain what add-on code this individual is asking about, so I can't respond to that question and know that I am responding directly, but I can tell you where to go for help. You can look to that document that I talked about that covers mental health services on the same day. I can tell you that a social worker can never bill for an incident to service, and that's how you started that question. Can a clinical social worker or psychologist bill for on and on and on. The clinical psychologist, or excuse me, the social worker can never bill for an incident to service. They can render an incident to service. But without knowing what code you're talking about and having access to code table edit lookups, I can't respond to that question. Any claim specific question or provider specific question can be answered by customer service though, but without knowing codes and having the tools to look them up, I can't tell you. Medicare can allow for some mental health services on the same day. I actually talked about that in one of my previous webinars. The recording for that webinar is available in on our WPS GHA YouTube channel. I think it was probably the third in the series. It was called Part B Mental Health Services, Bundled Services, or Unbundling, something to that effect. But if you look out in on the WPS YouTube channel, we have a playlist that includes recordings of all of those previous webinars in this series, and that will help you out.
Okay, thank you for that. We have another question, and it says, can residents in training bill incident to supervising physician in an outpatient clinic or group practice?
Well, you need to look back here to the requirements or the CMS key criteria for payment, and I don't believe that the resident is going to meet um, those employment relationship qualifications. If you have more information that you can provide to me, the learner that sent this question, I would encourage you to send me a follow-up question so you could provide more details to me. We will tell you in just a few minutes how you can submit those questions. So good question. I just don't have enough information to answer it right now. So if you could send more information into me, that would be great.
Okay, so it seems that we don't have many other questions. They're all around the same questions that you've
Okay.
answered so far.
Um, just I'm seeing just I'm seeing the chat kind of coming and going, and I know Bailey's monitoring those and asking me, but I am seeing a lot of questions out there where I am seeing social worker credentials listed within those questions. Can limited licensed social workers render Incident to services? And that's going to be based on your state scope of practice. If state scope of practice says that that credentialed social worker, whether they're enrolled in Medicare or not enrolled in Medicare, is qualified to render that service, then as long as the 5 key criteria for payment is met, Medicare can consider payment for an incident to service rendered by the clinical social worker or the social worker. However, we cannot pay a clinical social worker for services that other individuals render incident to them. So you can't bill for an incident to service if you're a social worker, but you may be able to render an incident to service whether you're enrolled or not. That is probably the most often question that I receive about incident to services, and that is whether the social workers can render the service or bill the service. And remember, it's really, really important to keep those two separate. Who can bill, who can render? And the rendering provider is the individual that's in that incidental patient encounter. So just try to keep those two straight, and that should help. All right, Bailey, I'm going to come back to you again to see if there are any other questions.
I just have one that came in, and it just asked for you to elaborate on PBB clinics.
The question that you're asking, I believe, is about provider-based clinics. And I am going to actually dig up some more information on provider-based clinics and get them out to those of you that attended today. So I would like an opportunity to do some more digging on that one so that I can give you the CMS information that you need for provider-based clinics.
All right, and last one that I see that has come in, can you describe general supervision again, please?
All right, let's go back to general supervision. General supervision means that the provider is not present. The provider doesn't have to be in the building. However, the provider still is responsible for the management of that patient. General supervision would apply for those behavioral health services that are furnished for diagnosis, evaluation, or treatment of a mental disorder or for substance use disorder with co-occurring mental health disorder. And again, how do you define behavioral health services? It's up to the provider to do that, and that's based on that information that we received from CMS. So if you're rendering a service incident to a qualified provider, one of those 7 individuals on that slide in this presentation, in this slide deck, those 7 individuals can bill for the service. They have to write the plan of care. Remember, it has to be a professional service. It has to be in a location covered for Incident 2 services. It has to be a non-institutional setting. There has to be an employment relationship between that rendering provider and billing provider. The service needs to be incidental, and then of course general supervision would be appropriate or payable, considered for payment if the service is a behavioral health service furnished for diagnosis, evaluation, or treatment of a mental disorder or substance use disorder with co-occurring mental health disorder, as opposed to direct supervision when the service or the supervising individual would need to be present in the office suite. Okay, general supervision does not require that the billing provider be present in the office suite or in the location of the service. All right. All right, just checking out to see if I can see any additional questions coming in. And I do not. So at this time, on behalf of myself and Bailey and the entire provider outreach and education team at WPS Government Health Administrators, I want to thank you for attending this webinar and wish you a great day. Thanks. You can now leave this webinar.